Hello everyone. In part 2 of chapter 15, we're going to break down the anticonvulsants. And there are quite a few drugs that have been utilized for anti-epileptic usage, and we're going to go through them in some further detail. So as you can see from this slide, and it's not the prettiest of slides, my apologies, I don't need you to memorize this, but I just need you to see how many different medications are utilized for anti-epileptic reasons. And obviously some of these drugs are older, have more side effects. Some on the right-hand side towards the bottom are newer and are considered a little bit safer, but obviously more expensive. And then we have some of the drugs in the middle, which they're sort of, some of them are falling out of favor. Some of them have very specific uses, and some of them are also utilized for other reasons, like long-acting barbiturates, such as phenobarbital. And then we have drugs like primidone, which I really don't think is used at all anymore. So it's just to say that, yes, there's several drugs, and we're going to pick and choose the ones that I think are most important to your career moving forward. First, let's just have a quick conversation about epilepsy. Epilepsy is a sudden, excessive, rapid depolarization of groups of cerebral neurons, which may remain localized or can spread to cause a generalized seizure. There's an increase in the electrical activity of the brain, and it can be either primary, for which there's no cause. It's either inherited abnormality of the brain, or basically a genetic component where the patient is treated for their whole life. Or we often see secondary epilepsy, which is due to several causes like infection, meningitis, encephalitis, brain tumors, head injuries, metabolic disturbances like calcium, hypoglycemia, excessive hydration, sudden withdrawal of alcohol from addiction, ingestion of drugs that can promote convulsions like CNS stimulants, caffeine, methylphenidate. And again, I think those secondary causes we see more so in the hospital setting, but certainly it's not the only place. So again, just a reminder of what we're actually talking about when we discuss these anticonvulsant drugs. Over the next 3 to 4 slides, I believe, I tried to break down the different types of seizure activity. And then basically just give you what is considered to be drug of choice as well as alternatives, because I think that's, when I look at your textbook, I think that's what maybe is missing, and what might be very useful for you moving forward. So drugs of choice for primary generalized tonic-clonic or grand mal is what it's also called, as well as partial seizures. They include phenytoin, valproate, carbamazepine, lamotrigine, and again, we're going to talk about all 4 of those drugs in detail. And then alternatives are the ones that are listed below. For partial seizures, all the drugs used are the same as above, except clonazepam you can also use. And that dose is generally about upwards of 20 milligrams per deciliter is the max, starting at 1.5 milligrams, milligrams per deciliter. Drug of choice for petit mal or absence seizures would be ethosuximide and valproate. You can also use clonazepam and lamotrigine. Drugs of choice for the atypical absence, myoclonic, and atonic seizures would be valproate as well as clonazepam and lamotrigine. And lastly, status epilepticus, which is something we certainly see in our hospitalized patients, especially for those of you who might be in the ER. And those drugs of choice are diazepam, IV, sorry for the strange font, that should say IV, not 1V, 5 to 10 milligrams, phenytoin, IV, 15 to 20 milligrams per kilogram. Phosphenotoin is safer, we'll talk about that. And then we still have phenobarbital IV, 10 to 20 mg per kg. In terms of anticonvulsants, again, factors that can precipitate seizures, we've talked about them, but just as a reminder, these would be those secondary factors. So things like sleep deprivation, which we see in the hospital, or sensory stimuli, children who are overstimulated, if you will, infections, fever, metabolic disorders, hormonal changes. Our adolescents tend to have a spike in the rate of epilepsy during high growth periods of their life, and hormonal changes, hyperventilation, stress. And again, anticonvulsant medications are being used in the treatment of mood disorders as well. And the anti-seizure drugs act by stimulating an influx of chloride ions, usually associated with the neurotransmitter gamma aminobutyric acid. They can also delay an influx of sodium or delay an influx of calcium. So let's talk about one of the classics, and that would be Dilantin and then phosphenotoin, which is Cerebix. So Dilantin or phenytoin is given either as a chewable tablet, oral suspension. It comes in capsules, extended release options. It's been around for a long time, so it has a lot of different options in terms of formulations. Half-life is about 24 hours. It can go higher than 24 hours. It can go up to 60 hours. When you just give a small increase in the dose, you can see that half-life jump right up to 60 hours. So the problem with Dilantin is toxicity, and that's why you have to monitor Dilantin or phenytoin levels closely, because toxicity is the main concern with utilizing this drug. Phosphenotoin, available only in the IM or IV dosing options. It's basically a water-soluble derivative of phenytoin. It's a prodrug, so it's given parenteral, and it's only given for about 5 days. It's the preferred drug in status epilepticus. So we're talking, I should have said, about the high dantoins, which is the drugs that we just mentioned, phenytoin and phosphenotoin. They work by stabilizing neuronal membranes, decreasing seizure activity by increasing an efflux or decreasing an efflux of sodium across the cell membranes in the motor cortex. So again, working on sodium ions. Onset and duration varies, and metabolism is in the liver, leading way to strong CYP2C9 effects. Levels will increase with cimetidine, diazepam, acute alcohol intake, valproic acid, allopurinol. If I haven't said it before, or if you haven't heard it before, somebody on a drug like Dilantin should never drink alcohol. You'll see, because again, high risk of toxicity, decreased effects will occur with barbiturates, antacid, calcium, and chronic alcohol use. Believe it or not, it doesn't mean that people don't drink alcohol. It just means they shouldn't. So somebody who's a chronic alcoholic will actually have a decreased effect, and versus an acute alcoholic intake will cause toxicity. And again, things like cimetidine and antacids will affect the levels as well. So again, older drug has considerably more adverse reactions, as well as considerably high half-life, which can cause problems as well. As mentioned, watch patients with liver and renal disease closely. As I just stated, many adverse drug reactions, including nystagmus, dizziness, pruritus, paresthesias, headaches, ataxia, hypotension, tachycardia, a lot of GI side effects. You will see often gingival hyperplasia in the mouth, urinary retention, urine discoloration as well. So again, I'll just let you read through those. Let's talk about another type of anticonvulsant. Let's talk about another type of anticoagulant, which would be valproic acid or valproate. Valproic acid acts by inhibiting enzymes responsible for the breakdown of GABA, which are GABA transaminases. And basically, when it's inhibited, there's an increase in GABA that occurs, and epilepsy is reduced. Its half-life is about 15 hours. Quite a few things you have to worry about with this drug as well. The classic, drowsiness, anorexia, vomiting, nausea that we see with a lot of these drugs, but also vertigo and tremors. You can get hair loss and skin rashes and urticaria type allergic reactions. Long term, we see weight gain due to an increase in appetite. So those anorexia, vomiting, nausea is more short term. Increased bleeding time due to thrombocytopenia, and it inhibits platelet aggregation. So you'd have to be careful if you had a patient who was also on antiplatelet medication. I would not put those two drugs together very often unless absolutely needed. And then we worry about some pancreatic and liver issues, such as pancreatitis and hepatotoxicity, where we have to watch the liver function tests on a regular basis. I would say every 3 months after baseline being normal. We have other anticonvulsants called benzodiazepines, and I know these are utilized for many different reasons, but clonazepam, nitrazepam, diazepam are utilized for antiepileptics as well. They control seizures on 3 parts of the brain. They work on the cerebral cortex, the thalamus, and the limbic area, and they also have a GABAergic effect, if you will. So they work on GABA. Diazepam is specifically used for status when it's given IV. It's not routinely utilized otherwise because it can produce tolerance. So generally we only think of this as an emergency type drug, but clonazepam you'll see utilized on a more regular basis. Adverse effects of the benzos include the classic drowsiness, sedation, lethargy. Some other things that are unique to the benzos are some respiratory depression issues, especially if other hypnotics are utilized at the same time or given at the same time. You have to be very careful with that. There's a muscle relaxant effect, and we can see hypotonia, especially in babies, dysarthria, anorexia, hyperphagia. In children, we can see paradoxical effects, and they're rare, but they would include restlessness, anxiety, and agitation. So again, paradoxical means kind of like opposite in relationship to what we see with the adults. If patient is taking a benzo for a prolonged period of time and the drug is withdrawn abruptly, we have to worry about status epilepticus, so it has to be tapered gradually. And I should say if given in pregnancy, we have to worry about floppy baby syndrome, which is that hypotonia, difficulty suckling. So for those of you who focus more on pediatrics, it's something that's pretty obvious if you see a baby that's been exposed. And again, there's really only one drug, which is listed on the first page, that we consider to be fairly safe in pregnancy. And I would certainly encourage anybody who has a pregnant patient to make sure that a neurologist is handling their anti-epileptic drugs during their pregnancy period. Drug interactions can potentiate the effects of sedative hypnotics and alcohol when patients are on benzos, which I think you've probably learned that in undergrad, but nonetheless. There's another group of anticonvulsants, the succinamides. There's 3 of them, And the most commonly used and most potent drug of the group is ethnosuximide. It acts by blocking calcium channels, the calcium T channels specifically in the brain. And it works mainly by blocking these channels along the hypothalamus, to be specific. The half-life is 50 to 70 hours, which is pretty impressive. As you can imagine, we have very similar adverse drug reactions: anorexia, nausea, vomiting, drowsiness, lethargy. But people can also have euphoria, headaches, and ataxia when we see higher doses. When patients take these drugs for a long period of time, they can have pretty extensive photophobia as well as Parkinsonian, I should say, like symptoms. In patients who also have psychiatric disorders, they can have restlessness, agitation, irritability, confusion. The blood dyscrasias we talked about, the thrombocytopenias, aplastic anemias, leukopenias, rashes. So, I mean, this is not a group of drugs without issue. I will say ethosuximide has a more potent effect than the other drugs listed, the methoxamide and the fensuximide. However, all of these drugs are being used, I would say, rarely, because in place we can use drugs like valproate. So again, they just have, I think, a little bit too many side effects, and with that half-life being so long, it's not the most widely utilized drug anymore. I'm just going to go through now sort of a random pairing of anticonvulsants for this last group, about 5 more slides to go. And I'm really looking at some of the newer drugs. So things like vigabatrin, lamotrigine, gabapentin, topiramate, tiagabine, zonisamide. And these are newer drugs. They're second-line drugs when patients don't respond to basically a lot of the other drugs we mentioned. They have 4 properties. Again, second line. They have a wide range of activity, so they're basically used in all types of epilepsy. They have minimal plasma protein binding, so they have less drug interactions, which we like. They do not have enzyme-inducing or inhibiting properties, so they have, again, less drug interactions. So, again, these newer drugs are more specific, have a wider effect in terms of who we can use them on, meaning in what types of epileptic pattern we're seeing. And basically, we're just waiting, I think, for them to be able to be utilized a little bit more frequently, meaning get coverage from insurance companies. I would be interested to ask my neurology friends if, in fact, these are the drugs that they're being able to get coverage for on a regular basis. I think we're almost there with that answer. So lamotrigine, longer half-life of 24 hours. I put that there because most of the other drugs are in this grouping, if you will, of what I'm calling newer drugs, are about 6 to 8 hour half-lives. How does this drug work? It's a wide range spectrum. It basically can cause sodium channel blockage as well as calcium channel blockage, so it can work on both. Mainly metabolized in the liver. We do have to just be careful in children. It can cause severe rash, and those rash can, kind of go down the path of Stevens-Johnson syndrome and cause death. Avoid that severe rash by giving drug in low doses, 100 to 300 milligrams in divided doses. Gabapentin, it interferes with the GABA metabolism, synthesis, as well as release and uptake. It's really not well understood, but we do know it's excreted in the urine. Half-life is 6 to 8 hours. It's used in mainly, all seizures as well as infantile spasms. It can also be used in neuralgias as well as neuropathic pain. So again, gabapentin isn't just used in this realm of anticonvulsant. Dosages range from 1.8 to 4.8 grams. You always want to start at a low dose. And again, those side effects are like what we saw with so many others: drowsiness and sedation, lethargy, that type of pattern. Vigabatrin is another newer anticonvulsant. It also inhibits GABA. It's used in all types of epilepsy, mostly used in patients with seizures and infantile spasms. Again, sort of similar to that gabapentin, but again, it's working in a similar fashion, so that makes sense. It can cause visual field defects when it's utilized long term. So some of its use is already declining because if we have other options that don't cause that, why would we not use that alternative drug? Start at a low dose, 500 milligrams. It can go up to 1,500 milligrams. And again, the half-life is about 6 to 8 hours. Topiramate blocks sodium channels directly, blocks calcium channels, has a GABA-mediated effect where it will help increase in GABA. Also has some inhibitory effects on excitatory neurotransmitters, used in all types of epilepsy. It's mainly excreted in the urine. It does have a longer half-life, 24 to 30 hours. It can cause urinary stones, or what we call urinary calculi. So we advise people to take in higher doses of water to try to excrete those calculi before they get caught in the urinary bladder, or the bladder neck, I should say. Dose is anywhere from 50 to 600 milligrams, always wanting to start again at a low dose. Tagabine is another GABA-related drug, increasing the concentration of GABA in the brain or in the brain synapses. It's mainly oxidized in the liver. About 75% of the drug is excreted in the stool, 25% in the urine. Has a broad range of activity, again, with all types of epilepsy. We do see depression in certain patients occurring, and again, starting at a low dose, closer to 16 milligrams, going up to 56 milligrams. So kind of some odd dosing numbers there too. And lastly, zonisamide. It's a sodium channel and GABA effect, like we've seen with the other drugs. Has a half-life of about 1 to 3 days. Quite impressive. Used in all types of epilepsy. Dose is 100 to 600 milligrams. We want to start at a lower dose again. I haven't said that once. I've said it, I think, 5 times now. And I don't think we know a lot about this drug yet. It's one of the newer ones, but again, just wanted to make you aware of it. Okay, that's a lot of drugs to talk about in terms of anticonvulsants, and I even pared it down from your textbook, so I'm hoping that is a help to you. And I will concentrate more on the slides for your exam, knowing how many drugs there are in this chapter. Thanks.